This is Sarah, registered nurse at RN.com, and in this video I'm going to be going over stroke. And this video is part of an NCLEX review series over the neuro system. And as always, after you watch this YouTube video, you can access the free quiz that will test you on this condition. So let's get started. First, let's start out talking about what is a stroke. It is where blood rich in oxygen cannot reach brain cells. And when this happens, cells begin to die after a certain amount of time. Now, what can cause this? What can limit blood flow to the brain tissue, those cells? Well, number one, a blockage of some type. In those vessels that feed the brain tissue, you can get a blockage, and that will stop blood flow from going to that part of the brain. And if it's stopped so long, that brain tissue can die, leading to severe consequences. Or that blood vessel can rupture, leading to bleeding, where all the blood's being spilled inside the brain instead of going to the tissue where it should be. Now, there are different types of strokes, and we're going to talk about ischemic stroke, hemorrhagic, and we're also going to hit a little bit on TIAs, which are transient ischemic attacks. So first, let's talk about ischemic strokes. An ischemic stroke is where you can have a blood clot within the vessel, or you have stenosis, which is narrowing of an artery, and it's not able to feed the brain tissue, and this limits the blood that can reach those brain cells. Now, this can happen due to a couple reasons. First, let's talk about an embolism type ischemic stroke. This is where a clot has left a part of the body, example, the heart. Maybe the patient has a heart valve problem, or they're in a rhythm called atrial fibrillation, where those atrium are just quivering, the blood is pulling in there too long, it can clot, and then it can leave the heart and travel to the brain, which will stop blood flow. And another type that can happen is a thrombosis type of ischemic stroke. And this happens when a clot forms within the artery wall within the neck or the brain. And this is seen in patients with hyperlipidemia, high cholesterol, or atherosclerosis. Now let's look at hemorrhagic stroke. Okay, this happens when there is bleeding in the brain due to a break in a blood vessel. And this will lead to no blood to be perfused to the brain cells, and you'll get excessive swelling from the leakage of the blood in the brain. Now, what can cause this? One thing that can cause this is a brain aneurysm. They have weakening of the vessel, it's bulging out, and it just bursts. Also, uncontrolled hypertension, so much force of blood going to the brain can weaken those vessels. Also, older age. As a person ages, the vessels aren't as resilient as they used to be, which leads to a decrease in their integrity, and they can break. Now let's talk about TIAs. Okay, this is an ischemic type stroke in its origin. So there's some type of blockage in that vessel preventing blood from getting to that brain tissue. Now, what makes it different is that it's a mini type of stroke. So it's not a full-blown stroke yet. It's one of those warning signs that, hey, something big is about to happen. So whenever a patient has this, they will have the signs and symptoms of a stroke. However, those symptoms only tend to last for a few minutes to hours and will resolve. So the patient just doesn't need to ignore this and think, oh, well, that could have been something else. They need to go, they need to get evaluated to make sure that, hey, this may be a stroke and we can treat it appropriately so they won't have those long-term consequences that could happen if they ignored it. Now let's switch gears and let's talk about the brain function and anatomy. This part of the lecture is really going to lay that framework for helping us understand those signs and symptoms and nursing interventions that we do for a patient with a stroke. And what I'm going to be doing is I'm going to be talking about the function of each lobe or each area of the brain, along with the right hemisphere versus the left hemisphere. Because test questions love to ask questions like, your patient had a stroke, they're having vision changes. What part of the brain is responsible for vision? Or they like to say your patient has language issues. They can't communicate with you efficiently. Which side of the brain, the right or the left side, is responsible for that? So you want to be keeping that in mind as I'm going over that material. So first, let's look at blood supply. What supplies the brain with all of its fresh, rich blood? Because in stroke, that's the issue. there's not enough blood getting to a specific part of the brain and it's causing the patient issues. Most of the blood supply that comes to the brain is through the carotid or vertebral arteries, and these arteries will branch off into other arteries and will feed these sections, and each area of the brain has specific functions, and you want to know what those functions are in order to be able to get those test questions right on those exams. Now, brain cells are super sensitive. They cannot go very long without that fresh, rich, oxygenated blood. And within as little as 5 minutes, these brain cells start to become affected. And the longer they go without that rich, oxygenated blood, the more affected they become, they can die, and it can be irreversible. There's no replacing those brain cells. So now let's look at the brain, and let's look at each section and see what its function is. Okay, we'll start in the front, so we'll go with the frontal lobe, which is represented in red, and it is responsible for our thinking, speaking, memory, and movement. And then right behind that in blue is the parietal lobe, and it's responsible for our language and processing touch. Then a little bit below that in yellow we have our temporal lobe, and it's responsible for hearing, learning, and processing our feelings. And then right behind that in green is the occipital lobe, and it is responsible for vision and how we perceive color, so color perception. And then a little bit below that in orange is the cerebellum, and it's responsible for balance and coordination. And then underneath that in purple, we have the brainstem, and it's very important. It helps with our breathing, heart rate, and temperature. Now let's look at the right side of the brain versus the left side. Okay, our right side of the brain is responsible for our creativity. So it helps us be creative, like with music and arts and things like that. On the contrary, our left side is our logical side. So it helps us with logic and helps us with things like reading, writing, speaking, and things like that. Now, how do you remember the two? How I remember it is that left starts with L, logic starts with L, so I know that the left side of the brain is our logic side and the other side is the creative side. So let's look at the right side. What does it help us do? Well, it helps us maintain an attention span. It also helps us show emotions and gives us the ability to solve everyday problems by making those quick decisions and those plans. Also, it helps us with reasoning, which gives us the ability to understand jokes and read in between the lines whenever we're conversing with people. Also, making judgment calls, having memory recall, and helps us with music/art awareness, and it controls the left side of our body. Now, let's look over on the left side. It helps us with speaking, writing, reading, math skills, analyzing information, and planning. So what happens when a patient has a right brain injury based on all those normal functions we just seen? Well, our left side is going to be affected. So what you're going to find is that the patient's going to have some left side weakness called hemiplegia. Also, they can have impairment of their creativity because that's our creative side of our brain. So they'll have issues with understanding and interpreting art and music. They will be confused on date, time, and place. They won't be able to recognize familiar faces or the person's name that goes with that face. They'll have loss of depth perception and trouble staying on topic while talking because remember, they're going to have a short attention span. In addition, they're not going to be able to see the things on the left side of their body. And this is going to lead to, I want you to remember this, left side neglect. And this is where they ignore the left side of their body. They're also going to have trouble with maintaining proper grooming habits. They can also be unstable emotionally. They're not going to think things through. They're going to be very impulsive, and they're going to have a poor ability to make decisions and assessing the spatial elements like shapes. Furthermore, they're going to be in denial about their limitations, which is going to put them at risk even more for injury because they're impulsive and they really don't realize how they're limited with this stroke. They're not going to be able to interpret nonverbal language very well or understand the hidden meaning of things. And like I said, they're going to have a very short attention span. So you need to keep that in mind when you're providing education or asking the patient to do something who has a right brain injury. Now let's talk about if a patient has a left brain injury. So again, the opposite side is going to be affected, the right side. So some findings you'll see is right side hemiplegia. Also, they'll have aphasia, and this is where they have trouble formulating words and comprehending them. And there's different forms of aphasia, like expressive and receptive, and we're going to talk in detail about those a little bit later on. Also, these patients are going to be aware of their limits. On the contrary, the patient with the right brain injury was not aware, but this patient will be aware of them, and they can experience severe depression, anger, and frustration, along with having trouble understanding written text. When they look at those words, they do not make sense to them. Also, issues with looking at numbers and interpreting math. Like the third point, they'll have impaired math skills. Also, they will have issues with writing, so agraphia, and their memory will be intact, and they can have issues with seeing on the right side of the body. Now let's look at the risk factors that increase a patient's chances of developing a stroke. And as I go through these, be asking yourself, which one of these are modifiable, something that a patient can change, or unmodifiable, something that a patient cannot really change? Because exams love to ask those questions, and they also love to ask about which patient is most at risk for developing a stroke. For instance, like smoking is a modifiable thing that a patient can stop doing to decrease their chances of stroke. However, if they had a family history of it, they really can't change that. They're stuck with that, unfortunately, because it's in their genetic code. So to help us remember all those risk factors, let's remember the mnemonic strokes happen. Okay, S for smoking. Smoking makes those blood vessels, decreases their integrity, so they don't work as well as they should, which can increase the chances of a stroke. T for thinners, specifically blood thinners. If a patient gets their blood way too thin, that increases the risk of one of those vessels busting in the brain. R for rhythm changes, and this can happen in those rhythms such as atrial fibrillation or a flutter, and the heart is not contracting properly, blood is pooling in the heart, and we don't want blood to congregate together long enough, because if it does, it can form a clot, and that clot can leave the heart and go to the brain. So it's important when patients are in those rhythms that they're being anticoagulated so they don't develop a blood clot. O for oral contraceptives, birth control. K for kin, the family history, they have a history of that. E for excessive weight, being obese increases the risk of it because remember, hyperlipidemia is one of those risk factors for developing stroke. So patients who are overweight tend to have high cholesterol, among other things. S for senior citizens. These are your patients who are elderly in age. Remember, advanced age, those vessels are not as resilient as they used to be, so that increases the risk. H for hypertension, uncontrolled high blood pressure. A for atherosclerosis. P for physical inactivity. Another P for previous TIA. Remember, we talked about that mini stroke. If they're having those signs and symptoms, but they're resolving, they still need to get it checked out because it could be a warning sign that, hey, a big stroke may be happening. E for elevated blood glucose, and this is specifically in patients who have diabetes, and this really traces back to how diabetes, that elevated blood sugar is so hard on those vessels. It, in a sense, just sticks to those vessels, hardens them up. They're not as resilient as they used to be, and it can lead to stroke. And then N in aneurysm, brain aneurysm, and this is where the brain vessels are outpouching in a sense, and they can rupture. So if the patient has brain aneurysm, not really aware, and they have uncontrolled hypertension, all that pressure hitting that vessel that has really lost its integrity can just rupture open and lead to that hemorrhagic stroke. Now let's talk about those signs and symptoms that a patient can experience whenever they're having a stroke. One thing it's important to know is that these signs and symptoms are going to happen suddenly. So as the nurse, you want to act fast, because acting fast is going to help save as many brain cells as possible. So if you are in the hospital setting and you start seeing these signs and symptoms, you'll want to call a rapid response or whatever your hospital has in place. Or if you're outside of the hospital, you would want to call 911. That's here for us in the United States. Another thing it's super important to do is to note the time when these signs and symptoms started. So if you don't know, ask the patient, or if you were there observing them, you want to take a look at your watch and you want to look at the time. Because the first question that's going to be asked is, what time did these signs and symptoms happen? Because if this is an ischemic stroke where there's a clot blocking the flow of blood to the brain, they can give a drug called tPA, which will dissolve that clot. But they only have a 3-hour window from the time that those signs and symptoms started, so you want to note the time. Now, what exactly are those signs and symptoms of a stroke? Okay, the National Stroke Association suggests using the term FAST to help you recognize common stroke symptoms. Because remember, they can come on suddenly without a warning. So the F is for face. So you'll want to look and notice a droop or an uneven smile on the person's face. Tell them to smile. If it's not symmetrical, that's a warning sign. A, look at their arms and note any arm numbness or weakness, and ask the patient to raise their arm. And if they can't raise their arm, it drops down like an arm drift or it's unsteady, that is a big warning sign. And then S for speech difficulty. Ask the patient to repeat something. Notice, how does their speech sound? Is it slurred, which can be indicative of the person having a stroke? And then T is for time. It's time to act. And also look at your watch, look at the clock, and note what time those signs and symptoms happen, and then notify the appropriate personnel. Now, in addition to those signs and symptoms that we just seen with the fast mnemonic, the patient can also have these unique signs and symptoms that is really geared to patients who've had some type of brain injury like with stroke. Now, as I go over these signs and symptoms of these terms, commit their definition to memory and know what they mean, because I can remember on nursing lecture exams, the professor would ask specific things maybe about aphasia, the different types, and we would have to know where maybe this type of aphasia was coming from, what area of the brain, or be able to describe how a patient with this type of problem would communicate with you. So just commit this to memory. Okay, so the first topic I want to talk about is aphasia. This is where they are unable to speak or comprehend the speech that you're speaking to them, or producing speech. And there's various types. The first type is called receptive aphasia. And this is where the patient is unable to comprehend the speech spoken to them. And this affects the Wernicke's area. And so whenever you're talking to the patient, they're not really being receptive to your speech. They're not really understanding it. Then we have a different type, which is called expressive. And the problem is that they can comprehend what you're saying, but they can't respond back with speech appropriately or even at all, depending on how severe it is. And the area in the brain that's affected with this, leading to expressive aphasia, is called Broca's area. Then you can also have a combination of both expressive and receptive, and this would be called mixed. And then there's global, where there's just a complete inability to understand speech or produce it. And this is in really severe cases of stroke. The patient can also have dysarthria, which is where they will be unable to speak clearly due to weak muscles. So they will be hard to understand. And that goes back to the slurred speech in the S of the mnemonic FAST. They can also have apraxia, where they can't perform voluntary movements even though their muscle function is normal. And this could be like winking, or they need to move their arm to scratch their other arm, something like that, like a purposeful movement they can't really do, but their muscle function is fine. They can also have agraphia, which is where they've lost the ability to write, and alexia, which they've lost the ability to read. They don't understand the text, or they really can't see the words. And notice that that word also comes from the word dyslexia, but this is alexia. Furthermore, the patient can also experience agnosia, which is where they don't understand sensations or really recognize known objects or people. For instance, you can show them a pencil and say, "What is this?" And they don't have the ability to connect the word pencil with that object. They may call it something else or just not even be familiar with it. They can also have dysphagia, which is where they have issues swallowing. So as a nurse, we really have to watch out for this because they are at major risk for aspiration, which can lead to pneumonia. And lastly, they can experience a condition of the eyes called Hemianopsia. And this is where they have limited vision in half of the visual field. And below this is a little example of Hemianopsia. And for instance, this is just a certain type. The patient maybe is looking and they only see in each eye half of the object that they're looking at, and the other part they can't see. So whenever you look at this word, just dissect it. Hemia means half, opmia deals with the eyes, so know that this is an issue with the eyes. And as the nurse, we really have to watch out for them with injury and teach them how to scan their environment whenever they have this type of condition, which we'll really talk about more in our nursing interventions. So now let's talk about how a stroke can be diagnosed and what can be ordered by the physician, because as a nurse, you need to know what can be ordered, what we should be looking out for. Okay, so the patient's having those signs and symptoms that we have just talked about. So what can happen is that the physician can order a CT scan of the head. One reason they like to do this whenever that patient comes in almost immediately is because they want to rule out if a patient has bleeding in the brain, like a hemorrhagic stroke. Because if they do, they're not a candidate for tPA. So they can't receive this because this will make them bleed even worse. Also, they can have what's called an MRI, look at the brain, see what lobes and areas of the brain have been affected by the stroke. That can help with diagnosing it. So let's talk about tPA. This is tissue plasminogen activator, and this is used only for ischemic strokes. So again, those were the type of strokes that were caused from a clot of some type that's maybe broke off from the heart or is formed in the brain, and it's stopping blood flow to a certain area of the brain. It is not for hemorrhagic type strokes. So how does this medication work? It works by dissolving the clot that is found within that vessel by activating the protein that causes fibrinolysis. So you get the breakdown of that clot, and when that happens, blood's going to go back to that brain tissue that severely needs it. However, there's a catch with this drug. It can only be given within 3 hours from the onset of those signs and symptoms. So it's very important the patient knows, or as a nurse who was there whenever the patient started having those signs and symptoms, what time they occurred. Now, there are some exceptions within the 3 to 4.5 hour range. If the patient meets strict criteria, they may be able to receive this, but the physician will have to analyze that. So what are some criteria that a patient should meet before they receive tPA? And as a nurse, I would remember these. Okay, first they need to have a CT scan of their head, and it needs to be negative for any bleeding, which could be a hemorrhagic stroke. We don't want to go in and throw more of this type of medication in there because we will increase their chances of bleeding out. Also, their labs need to be within normal limits, and labs that aren't normal, they can be corrected before this medication is given, like glucose should be within a certain parameter. They shouldn't be hypoglycemic or hyperglycemic. Also, their clotting levels like INR and platelets should be within normal range, and their blood pressure needs to be under control. A lot of times when a patient comes in with stroke symptoms, their blood pressure is through the roof. So they need that to be under control. So as a nurse, you're going to be giving some antihypertensives to bring that down. You want the systolic to be less than 185 and their diastolic to be less than 110 before giving tPA. And while they're getting tPA, you want to keep that blood pressure within a good range. Also, it's important that they haven't received recently any drugs like heparin or any other anticoagulants, because we're going to throw some more type of drugs in there and we don't want to increase their chances of bleeding. Now let's talk about nursing interventions. Okay, say you have a patient, they received tPA. What are you going to be doing as a nurse? What are you going to monitor them for? You want to monitor them for bleeding, and you will be doing around the clock neuro checks, checking their neuro status using the NIH stroke scale, which is what we're going to be looking at here in a second. You're also going to be giving them blood pressure medications if they need it to keep their blood pressure within a certain parameter, and looking at those other vital signs, monitoring their glucose, and making sure that they're on bed rest. They don't get up, fall, because if they fall while they've received this, it could lead to intense bleeding, and we want to prevent injury. Also, no IM injections, and avoid unnecessary IV sticks, drawing blood, things like that. And most cases, patients will go to the intensive care unit, ICU, to be monitored usually the first 24 hours after they have received this medication. Now, as a nurse caring for a patient who's experiencing a stroke, you're going to be assessing them using some type of stroke scale. And a common one is the NIH stroke scale, and it assesses 11 different areas, such as the patient's level of consciousness, their gaze, their visual, their facial palsy, motor function of extremities, sensory, best language, dysarthria, and extinction/inattention. And the scores range from 0 to 42, with 0 being no stroke symptoms at all, and the worst score is 21 to 42, with that being severe stroke symptoms. Along with that, you're also going to be monitoring for a lot of things, and especially in that acute stage, you want to be monitoring their vital signs, looking at their blood pressure, making sure they're not hypertensive, their heart rate, their respirations, because they are at risk in those first several hours for developing increased intracranial pressure. So you want to make sure they're not having that. And that can present with an increased blood pressure, decreased heart rate, decreased respirations. The patient can also suddenly start having nausea and vomiting. Their level of consciousness can change, and their pupils will not respond at all. So you want to be looking for all that. Another thing is you want to be monitoring that airway very closely, because remember, they're going to have issues, depending on what type of stroke they've had, with swallowing. So all those oral secretions are just hanging out in there. They're not going to be able to swallow them. So they're at risk for aspiration. So you want to make sure that you have suction hooked up and ready to go for whenever you need it. Assessing those cranial nerves as well, like the pupils, their ability to swallow, the facial nerves, their gag reflex, and things like that. And if you're not familiar with how to assess those cranial nerves, you can check down below in the description for a link to a video with the head-to-toe assessment that will show you how to do that. Also, you want to assess their bladder and bowel function, because patients can either have incontinence or retention. So you want to be making sure you offer them the bedpan, bedside commode if they can even get up. Also, they may need a Foley catheter if they're retaining urine. And an easy way to check if they're retaining urine is that you can use a bladder scanner and scan the bladder with, put a little bit of ultrasound jelly and get your little bladder scanner, and it can tell you if there is urine in the bladder and how much. Also, you want to be maintaining skin and limb integrity. If they have where they can't move one side of the body, you need to be repositioning them every 2 hours, performing those passive range of motion techniques with their arms, their legs, and making sure that they have proper body alignment because they can't really do this. And one thing you want to watch out for, and I want you to remember this, it's in orange, I have it right here, called neglect syndrome. And it's also sometimes called unilateral neglect. We talked a little bit about this earlier, and this happens when there is a right side injury, and this is literally where the patient ignores that affected side, and it's usually the left side. So some nursing interventions to help with this. You want to monitor the patient for it, see if they're having this, and you want to constantly remind the patient to make a conscious effort to use and to touch that affected side of the body that they are neglecting, and also to constantly scan the environment to look all around to look for any type of injury that they could do to that affected side. And this leads to another thing that the patient could experience called Hemianopsia, and this is what it looks like. Notice whenever you're looking at this image, you can see that half of the visual field is gone, but they can see the other part. This is just one type of hemianopsia that a patient can experience. So as you can see, if you don't have good vision, there's a chance that the patient can injure themselves. So to assess for this, you want to show a patient something and tell them to describe what they see if they are having abnormal vision, and teach them to prevent injury to always scan the head side to side, to always look in all the visual fields to make sure that they're not going to run into something or fall or something like that. Now, next, diet, because what is one of those things a lot of patients with strokes can experience? Difficulty swallowing. And as you're going to see whenever you work in the hospital taking care of patients with strokes, this is a multidisciplinary thing. You're going to have speech therapy involved, physical therapy, occupational therapy, and as the nurse, you're going to be receiving treatment plans from them, and you'll be following them out. So this just isn't all nursing. It's all of us working together to care for this patient, along with their family. One thing I want to note is that if the patient has family with them, you really want to incorporate the family in the patient's care as much as possible, because a lot of times these patients are going home with the family, and the family needs to know what to expect and what's going on. So diet. They will be evaluated by the speech language pathologist, who's going to do a swallow study on them, see how they're swallowing. Also, they're going to work with them if they have difficulty with their speech, helping them be able to communicate more effectively. A lot of times they're recommended to have thickened liquids, no thin liquids, so always remember this whenever giving medications or helping them with their food. Do they need honey thick, nectar thick? And if you're going to need to crush medications and put them in applesauce. Also, a lot of patients are going to follow a mechanical soft diet where the foods are soft, easy to swallow. And a lot of times you're going to be assisting these patients with eating their food. So as the nurse, you want to watch out for yourself or your CNA who may be assisting with this, or the family member, to watch out for the patient pouching food in their cheek on that affected side that's weak, because a lot of times it can just fill up with food, and if you're not aware of this, this can cause aspiration from where that food contents can go down into the lungs because they've just kept it in the cheek. And also, if the patient has a lot of trouble swallowing, to prevent them from choking and gagging, things like that, they can tuck their chin to their chest while they swallow, and that will help assist and guide that food down. Now let's talk about communication, specifically how to communicate with a patient who has aphasia. One thing you want to remember about a patient who has difficulty communicating with you is that they don't have a mental deficit. They're not unintelligent. They don't have something like that wrong with them. It's just that they can't properly communicate with you or understand you as fast as they used to be able to before they had the stroke. So as the nurse, what we can do is we can help, in a sense, bridge that gap a little bit and make it less frustrating for our patients. So if they have receptive aphasia, that is where they are unable to comprehend what we're saying. So we may be saying things to them and those words are just not coming to them to make them understand what we're saying. So sometimes there's a delay in their ability to understand our question. So what can we do? Well, whenever we communicate with them, we can use short phrases and simple details. Don't go on and on. Also, use gestures and point to things that we're talking to them about, because if we want them to use the bedpan, we can show them the bedpan, and they may not understand that word we're saying, but since we're pointing to it and using that, they'll get the idea. Oh, they want me to use the bedpan. Be patient with them. Don't rush them or just walk off because you think that they can't understand you. Take your time with them. In addition, remove any distractions, because a lot of times these patients have short attention spans, or they hear words coming from the television along with the words coming out of your mouth, and it's just too much to decipher. And another great thing is repeat and repeat. Repeat those questions over and over, those commands. Rephrase them, or just keep repeating them over and over, and eventually it'll click and they'll be able to comprehend. Now, with expressive, what do? This is where they can comprehend what you're saying. So they know what you're saying, but they're having trouble putting the words of how they want to respond back to you. Some patients can't respond at all, or some patients don't use the right words to respond. So with these patients, again, be patient with them and let them speak. Don't rush them or try to fill out the sentence of what they're trying to say. Let them say it. Another thing is ask one question at a time. Don't ask them 50 questions where they have to give you 50 responses. One question at a time. And let those questions be direct, and ask the question in a way where they have to give a simple response to you, not a huge descriptive response. And another great thing with these patients I've found is to use a communication like dry erase board, pencil, piece of paper, and that will help them communicate what they need to tell you. Okay, so that wraps up this video over stroke. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.